Let's begin our exploration of history-taking. This is a fundamental building block in our diagnostic journey, so pay close attention. We'll examine the key strategies and techniques for gathering this vital information. Now, let's think about this. What is the purpose of the history? Why do we, as doctors, invest time and effort in taking a thorough patient history? The history begins even before the first question is asked. The initial meeting and observation of the patient is crucial. Imagine walking into your office and you notice a patient struggling to walk, or they are guarded in their movements. This is the first clue we gather, even before a word is spoken. The first and most important rule of a good history is to be present, to be fully engaged as you approach and retrieve the patient. The history encompasses a multitude of factors and questions. Common questions include timing, onset, mechanism of injury, pain quantification and qualification, location of pain, exacerbating factors, relieving factors, and functional deficits. Remember, these common questions are just the starting point. Diagnosis-specific questions are crucial. We will organize these questions into folders to help you structure your thought process for the various pathologies we'll discuss in this course. It's a valuable tool to help you navigate the complex world of diagnoses. Now let's explore how to truly create a safe space for the patient to reveal their full story. Give your patients the freedom to fully describe their symptoms. It's vital to create a safe environment for them to reveal all the factors related to their pain. Don't jump in and answer the questions for them or assume what they are thinking. Let them tell their story. All right, let's look at the cervical spine. The way a patient presents themselves in your office is a powerful indicator. This can include how they appear in pain, anxiousness, altered gait, guarded postures, balance difficulties, and what they initially report. Remember, these presentations are full of important information. Observe the patient's posture and any guarding behavior. Is it difficult for them to move from sitting to standing? Do they exhibit balance difficulties? Are they being assisted by family members? Notice the family interactions. Is there tension? Pay close attention to facial expressions and how their gait is affected. Is it antalgic? Does their balance seem off? What is their gait velocity? Now that we've touched on initial observations, let's shift to the importance of establishing a strong professional connection with our patients. It's crucial to greet your patients professionally, even student patients. No slang allowed. Remember, your patients are not your friends. Don't say things like, "How you doing?" or "What's up, man?" or "Hey, bro." You are a doctor, and your patients expect you to behave like one. Now, let's discuss eye contact. Some cultures do not support direct eye contact in all situations. But if you plan to practice in the U.S., it's important to learn how to make eye contact as you communicate. Look the patient in the eye when greeting them. Acknowledge their spouses or family members. Looking away while shaking someone's hand is highly disrespectful. Be conscious of the social baggage you bring into the exam room. Be aware of your own bias and prejudice. Your personal feelings about race, ethnicity, religion, immigration, nationality, socioeconomic status, sex, sexual preference, sexual identity, age, geopolitical relations, and political affiliations can negatively affect how you listen to, feel towards, and treat your patients. If you are aware of having social bias or cultural issues, it's essential to seek counseling to address these issues before you begin full-time practice. Social bias or cultural issues can cause you to neglect your duty due to disdain for the patient. This is unethical and may lead to pain and harm for the patient. This could also be the basis for a malpractice case. Let's move on to one of the most crucial aspects of a successful history: listening. Are you truly capable of listening? Make sure you listen to everything the patient has to say. Many patients will tell you that no doctor has ever truly listened to them. It's tempting to jump ahead and try to derive a diagnosis without all the data, but this leads to a myopic and ineffective approach to care. Be present during the history and exam. Your mind may wander during the history. Bring your awareness and focus back when this happens. It's a learned skill. Use patient quotes as much as reasonably possible during the history. The patient needs to feel comfortable describing all their symptoms in any way they can. It's their body experiencing the symptoms. It's our job to gather the data and derive a conclusion. As we mentioned, patients need to feel comfortable describing their symptoms. You will hear very painful and deeply personal histories, including reports of psychological abuse, physical abuse, sexual abuse, rape, incest, domestic violence, substance abuse, and more. You need to be professional, patient, and provide a safe environment for the patient without judgment. You cannot sigh, tap your pen, wiggle your feet, or stare into space while taking a history. What do all of these actions communicate to the patient? Don't interrupt the patient unless it's to clarify a statement or response. Patients may have been rushed by previous doctors and never told the full history of their injury or symptoms. Patients may begin to edit their history because they think the doctor isn't listening. Vital information can be lost this way. If a patient says, "I will give you the abridged version of what happened," respond by stating, "Please don't give me the abridged version," or "Please give me the entire story." Some patients do need to be redirected during their history. This can be achieved by simply asking the patient questions to bring them back on track. The healthcare world is rapidly changing and is in turmoil. These changes can restrict the time spent with the patient. You must learn to be efficient. We have seen the complexity of past and current changes in healthcare. No one knows what the future healthcare landscape will be, although the next wave will most likely have payment based on diagnosis. So, your income may be directly related to your ability to derive a diagnosis. It is often stated that the history is 80% of the diagnosis. Some feel it is 90% of the diagnosis. Therefore, it is very important to listen carefully and pay close attention to details in the history. One description or one statement by the patient can sometimes be the clue to direct you to the appropriate diagnostic path. We will continually revisit these concepts throughout the semester. Let's shift gears to understanding how we can differentiate between orthopedic and systemic pathologies. How does one differentiate an orthopedic pathology from an organic/systemic pathology? There's a general principle that can help us. What is it? An orthopedic/musculoskeletal pathology should have a position that makes the symptoms better or worse. An organic/systemic pathology does not have a position that will exacerbate or relieve symptoms. There is no position to relieve or exacerbate the symptoms of passing renal calculi, myocardial infarction, pulmonary emboly, etc. Remember, the diagnosis will determine the treatment plan. You may not be able to determine the plan until the diagnosis is clear. Treatment efficacy is not a system of throwing a random treatment at an ill-defined problem and hoping it works. This is inappropriate, usually ineffective at best, and is costly to the patient and the healthcare delivery system. As new young doctors, you need to avoid the pitfall of rushing to a diagnostic conclusion. Doing so will likely lead you to the wrong conclusion. Make sure you allow yourself to consider the differential diagnoses and think about the logic of what you are considering. The diagnosis must make sense. Now let's move into the more specific information we gathered during the history. We'll collect basic information from the patient, including location. Ask the patient to use one finger to point to the pain. Why? Because it gives us a precise understanding of their pain. Quality. Is it sharp, dull, aching, burning? Quantity or severity. How bad is the pain on a scale of 1 to 10? Timing, including onset, duration, and frequency. When did the pain start? How long does it last? How often does it occur? Setting. Where do the symptoms occur? Factors that aggravate or relieve symptoms. What makes the pain worse? What makes it better? Folder questions will follow. Is the injury consistent with the mechanism of injury? Does the patient have night pain? What does this mean to you in week 1 of DDXI? We need to know about any prior trauma or symptoms. Have they had previous evaluations? Who rendered the evaluation? This can reveal much. You will soon learn which doctors in your community have a high diagnostic accuracy and successful treatment outcomes. Conversely, you will learn which doctors to avoid. Ask about previous tests and results. Obtain copies of imaging reports directly from the imaging facility and not from the ordering physician. I suggest you read the imaging results after your physical exam. Don't allow your clinical diagnostic opinion to be influenced or misdirected by possible incidental findings. There are exceptions to this rule, such as a history of cancer. Obtain copies of the actual imaging studies, which are usually on a CD today. Some facilities may give you access to their PACS system to view the images yourself on your office computer. You will sign a HIPAA compliance agreement to do so. You need to view the images. Do not rely solely on the reports. Your HIPAA agreement with the imaging facility will permit you to view your patient's images only. If you have a patient presently under your care who had imaging ordered by another doctor, you have the right to view these images too. If you view images of people who are not your patients, you will violate HIPAA. At the very least, you will be removed from the PACS system, and most likely, the imaging center will no longer scan your patients. If the imaging center informs the patient that you violated HIPAA by viewing their images, you could have legal complications. Let's highlight the serious consequences of violating HIPAA. 50 staff members were fired from a Chicago hospital for viewing the medical records of Jussie Smollett in March 2019. Every movement is tracked on electronic records and PACS systems. Every keystroke is known. Be compliant or face the consequences. We need to know about previous treatment and the outcome. Is the clinical data consistent with the tests, or does there appear to be more than one diagnosis? Poor use of Occam's razor can cause the doctor to miss much pathology. First, ask all-encompassing questions first to help prevent the patient from determining what you want to hear. Second, then ask specific questions without putting answers in the patient's mouth. Patients may anticipate questions. If the patient's answers suggest new clinical information is present, the doctor must pursue this information diligently. The history is 80% of the diagnosis, assuming the doctor actually performed this task well. Ask repeatedly, is there anything else you can tell me? What else can you tell me? Are there any other symptoms? The problem you will face as interns is that you are not proficient yet in obtaining histories and performing thorough and accurate examinations. Exam flow has not yet been developed by students or interns. Organization of thought processes has not been developed either. You will be pushed to speed the process of obtaining histories and regional exams to try to make you more efficient. You will need to come full circle once you can quickly obtain information with clear focus. The circle will bring you back to the point that you are efficient, and now you need to listen, observe, and actively inquire and pursue the diagnosis. This takes time. You will be surprised by the additional information you will acquire when you keep trying to gather the entire history. Let's move on to a different section of the history, the past history. We need to gather information about the patient's past, including previous surgery, previous trauma, previous hospital stays, childhood diseases, adult illnesses. Note, HIPAA requires HIV status and substance abuse data be kept on a different page and is not part of copied notes unless specified by the patient or demanded by court order. Electronic records may create an issue with this. It's crucial to obtain information about the patient's family history, including age and health of parents. Respectfully ask if parents are living. Ask, are your parents still with us? If deceased, ask about the cause of death and age at demise. Number of siblings, sex, ages, and health. Number of children, sex, ages, and health. We are particularly interested in familial history of cancer, cardiovascular disease, hypertension, elevated cholesterol, CVA, diabetes, arthritis, and the chief complaint. We gather social history information to gain a better understanding of the patient's lifestyle. Marital status: single, married, separated, divorced, widow, domestic partner. I always take this information from the patient intake form or e-page. Why? Because it provides context about their support system and social environment. Smoke, PACS, /X years, quit when, alcohol consumption, drinks / week or occasional, rarely, none. We also gather information about their activities, current or prior to injury. This can give the doctor a clue to the extent of disability. We also ask about their occupation. Details can be separate, especially in a workman's compensation case. We collect information about current medications, which is important information and insight into the patient's overall health. There are other reasons too. Fluoroquinolones, such as Cipro for UTI, can cause spontaneous rupture of tendons. Levaquin can also cause muscle strain, tendinitis, and tendon rupture. Lipitor can cause musculoskeletal pain, even rhabdomyolysis. Accutane can cause musculoskeletal pain, including LBP. We need to know about OTC medications, including frequency and dosage. We also ask about any allergies to medications and the reaction. For example, the patient may respond with penicillin. You then follow up with, "What happens if you take penicillin?" And the patient replies, "My throat closes." This is an allergic reaction. Remember, an allergic reaction is different from an adverse effect. For example, the patient may respond with Vicodin. You then follow up with, "What happens if you take Vicodin?" And the patient replies, "I feel nauseous." This is not an allergic reaction, it is an adverse effect. We also gather information about supplements. Note anticoagulant supplements, including omega-3 or fish oil, turmeric/curcumin, garlic capsules, ginger capsules, pomegranate juice. You need to know this, as do any doctor you refer your patient to for surgical or pain management care. The largest chiropractic malpractice lawsuit award occurred in 2013 for the amount of $5,500,000. This involved multiple anticoagulant supplements and NSAIDs. Now, let's discuss other physicians. Who is the referring physician? This is the person to whom you will send a report. You do not need HIPAA permission to communicate with the referring physician unless the patient explicitly instructs you to not communicate with the referring doctor or any other doctor. We also ask about the patient's primary physician and their city of practice. We also ask about specialists, orthopedic surgeon, neurologist, cardiologist, OB/GYN, other chiropractor, etc. The review of systems provides us with one last chance to review all systems and ensure that pathologies were not missed. Develop a consistent set of questions for review and note them. Do not be inconsistent with abbreviations. It will catch up with you one day if you are inconsistent. Now, let's go through some specific questions for the review of systems, beginning with the head and neck. Headaches, previous head trauma/concussions, dizziness, visual disturbances/problems, hearing problems, ringing in the ears, balance difficulties. Let's continue with the head and neck. Facial numbness, neck pain, sinus problems, dental health, sore throats, hoarseness, difficulty/pain with swallowing. Now, let's move on to the chest and heart. Chest pain, hypertension, shortness of breath, include exercise-induced asthma, use of inhaler, arrhythmia. Let's look at the gastrointestinal system. Difficulty swallowing, heartburn, GERD, history of gastric ulcer, colitis, change in bowel habits and color, pain after meals. Let's continue with the genitourinary system. Kidney stones, blood in urine after trauma, UTI, hernia history, STDs. Now, let's examine the endocrine system. Menstrual cycle, thyroid function, serum glucose. Now, let's revisit the spine, review or note the chief complaint again. For the extremities, review the upper and lower extremities, arthritis, and include the question, is pain worse in the morning or evening? Also, include extremity, particularly lower extremity, swelling, redness, and pain. I advise you to review the chief complaint with the patient after you complete the history. This review avoids conflicts that can arise later in reports. For example, patient states, "I never said that," or in communication between physicians, "That's not what the patient told me." This review also sharpens your skills and verifies your ability to obtain an accurate patient history. Informed consent is a crucial aspect of patient care and is mandated by the California State Board of Chiropractic Examiners. DCs are required to give the patient treatment options and possible outcomes. Required to give the patient possible adverse effects of treatment and the probability of the risk occurring. You must also advise the patient of the risks or benefits from not receiving care. Remember, the treatment is based upon a diagnosis. A famous quote by Norman Shore, MD, a prominent oculoplastic ophthalmologist at the Jules Stein Eye Institute, UCLA, aptly emphasizes the importance of informed consent. A discussion before a procedure is an explanation. A discussion after a procedure is an excuse.